Welcome everyone to the let's get some feedback. I'll just double check on that. Yeah. Well, my computer over here. This isn't really very good.
Oh, wait, actually.
Oh, easy. Technology. Welcome everyone to the China Seminar Series hosted by the Australian National University and the Center of China in the World here. My name is Matthew Galway. I'm a senior lecturer of Chinese history here, focusing on global Maoism, and it is my pleasure and indeed my honor to welcome Professor Fang Xiaoping of Monash University to give a talk on the Barefoot Doctors. Before we begin, I'll just begin with an acknowledgement of country. Now, again, we acknowledge and celebrate the First Nations, the Ngunnawal and Ngambri peoples on whose unceded traditional lands we meet, and we pay our respects to the elders past and present. So without further ado, we'll pass things over to our speaker today. I'll just provide a brief introduction of Professor Fang's brilliant work. In the history of medicine and health, the Barefoot Doctor scheme in China during the Cultural Revolution was a synonym for the provision of rural healthcare in Maoist China, and Fang's work is indeed at the forefront of this. He's an associate professor of Chinese studies at Monash University, and his research interests focus on the history of medicine, health, and epidemics in 20th century China, and the socio-political history of Maoist China after 1949. He's the author of Barefoot Doctors in Western Medicine in China, which came out with the University of Rochester Press in 2012, in China and the Cholera Pandemic, Restructuring Society under Mao, which came out with the University of Pittsburgh Press. Go Panthers! I was very graciously provided a copy, and I can't wait to sink my teeth into it. This piece was, of course, the winner of the 2022 Outstanding Academic Title at the Choice Awards. So without further ado, our speaker, Professor Fang Xiaoping.
Thank you, Matthew. I'm very grateful to the CIW and Matthew for inviting me to give a talk at the CIW. And thanks for Melody's arrangements. And thank you all for coming to the presentation. I know everyone is busy nowadays. And I'm very glad to know that you are still interested in my Barefoot Doctor research, because I completed this research a few years ago. Now I'm working on over the past few years, I'm working on the cholera pandemic, now working on the other topic. In the global history of medicine, the Barefoot Doctor scheme in rural China during the Cultural Revolution was a synonym for medicine and health in the People's Republic of China. And it is widely argued that the Barefoot Doctors provided a low-cost solution to the huge populations of health provision with limited medical resources and a suitably revolutionary image. My research based on village center and field work-based and sonographical study argues that a key impact of the Barefoot Doctor program was facilitating the entry of the Barefoot Doctor of the Western medicine into villages that were hitherto dominated by Chinese medicine in terms of scientificization, institutionalization, and professionalization, which led to marginalization of Chinese medicine. In this talk, I will introduce how socio-political, disease, and economic factors contributed to the development of the Barefoot Doctor program and shaped the unique path of the health provision in China over the past 7 decades. It analyzed how the government clarified and addressed the contradiction between the ideological equity and the structural inequity. And I will discuss how the epidemiological transition both facilitated and challenged the Barefoot Doctors program. And I will further investigate how the changing roles of Barefoot Doctor has impacted the evolution of the community medicine since the late 1960s. And I discussed how the Barefoot Doctor echoed the themes of the medicine and health in both the developing and developed country, and left its inspiration and the legacy. as early as the 1930s, both the governmental and non-governmental groupings and practice aimed to serve persons who counted for more than 85% of China's total populations and trained sufficient medical staff for rural areas in the state medicine framework. And the structural design of the China's rural medical system continued across the nationalist and communist eras. And after 1949, as one of the key measures to improve medicine and health in rural China by the newly established communist government, some agricultural co-ops established healthcare stations during the agricultural collectivization campaign of 1953 to 1957. By 1965, in response to a serious shortage of the medical personnel, and the central governments require each production brigade to select 2 youths to serve as healthcare workers, or half peasant or half doctor, Fang. In the suburban counties of the Shanghai municipality, villagers usually called these healthcare workers the barefoot doctors because they labored barefoot in the rice paddy fields, but they were ready to do the medical and health work as needed. So on 14th September 1968, the People's Daily published an investigative report fostering a revolution in medical education through the growth of the barefoot doctors. It describes the work of the barefoot doctor in Jiangzheng Commune, Changsha County, Shanghai municipality. The location is not far from the Pudong International Airport of Shanghai. Starting in 1969, the Barefoot Doctor program was promoted nationwide together with the cooperative medical services. They formed the lowest levels of a 3-tiered state medical system that comprised the county, the People's Commune, and the production brigade levels. So each production brigade implemented the cooperative medical services to cover the cost of establishing these medical service stations, which would be presided over by barefoot doctors. And as a new medical and health scheme, barefoot doctors significantly changed the delivery method of healthcare and transformed medicine and health in rural China. In terms of knowledge transmission, the healers that made up the Chinese rural medical world prior to 1949 follow the long-standing family-based or apprenticeship-based tradition, and in both cases were confined to the local community. Furthermore, the medical knowledge, techniques, recipes, and the healing experience were not readily shared with others or family, the people outside their families and clans. So, however, the new election criteria for barefoot doctors emphasize the age, gender, and educational background. This ensured that the barefoot doctor come from ordinary rural family rather than the village elites, as with traditional practitioners. The scheme therefore quickly increased the number of the people with medical knowledge in the villages. Gender was particularly significant, as these features set the barefoot doctors apart from existing professional Chinese medicine doctors and focal healers in the villages. So large-scale medical publication also facilitated the knowledge of knowledge dissemination within the advent of the barefoot doctors. Textbooks such as the textbook for barefoot doctors that especially target them were also soon published and widespread. A barefoot doctor also demonstrate a unique pathway, the trajectory of professional development. In 1970s, barefoot doctors were mainly responsible for the medical and health work of their own production brigades, and they did not intervene in each other's geographical domains. which minimized the competition between the colleagues in neighboring villages. Inside the cooperative medical station of their own production brigade, the non-profit orientation of the cooperative medical services and the salary calculation method based on the worker point scheme also minimized the conflicts among the barefoot doctors in terms of the personal income and professional prestige during the 1970s. All these contributed to the formation of the sense of the group identity. For villages, after the advent of the Barefoot Doctor program, access to pharmaceuticals significantly changed. Beginning in the early 1950s, modern Western medicines, vaccines, and medical instruments were gradually introduced into villages as the newly formed state pharmaceutical sales and network extended its national reach. After 1968, the cooperative medical station and the medical kits of barefoot doctors extended the pharmaceuticals network throughout rural China at an unprecedented pace. The Western pharmaceutical, mainly the antibiotics and sulfur drugs, vaccines, began to enter the countryside and even reach the broad areas on a large scale. So meanwhile, the consumption of Chinese herbal medicine and the focal medical practice were promoted to meet the demands of the national health program in view of its low economic cost. And this brought about the structural changes in the pharmaceutical consumption and a rapid rise in the use of the low-cost Western medicine and the onset of a progressive marginalization of Chinese medicine in daily medical practice in villages. So as the medical staff at the lowest level of the three-tiered medical system, with the counterpart at the commune and the county level, the barefoot doctor finally accomplished and enhanced the technical stratification and the cooperation of a medical system. Through the patient referral system, the barefoot doctors were instrumental in bringing the radical changes to the rural population due to their integral role in the process of implementing medical institutionalization into Chinese villages through the establishment of a hierarchical medical system and the formalization of medical encounters between the patients and the doctors. In the meantime, the proximity of the personal relationship between the barefoot doctors and the villagers in the tightly knit community made a relatively positive impact on the doctor-patient power relations in the villages. The medical transition brought about by barefoot doctors occurred in a broad, complicated social political context, which shaped the social determinant of health and the relationship between the medicine and the social justice. The political discourse of the Cultural Revolution claimed that the barefoot doctors and the cooperative medical services were great inventions made by poor and lower middle peasants to combat diseases by depending on collective forces because they solved the problems of the poor and the lower middle peasants seeking medicine and health care. In this sense, the barefoot doctors justified the revolutionary commitment to the equity and the justice of the medicine and health as the newly emerged themes of the Cultural Revolution. The political legitimacies of barefoot doctors were further buttressed by top-down administrative and the medical system composed of the county, the People's Commune Production Brigade in the new central and local relationship promoted by the Cultural Revolution and Mao's rural development strategy. However, the Barefoot Doctor program was implemented nationwide in the historical context of Chinese urban-rural dual socio-political structure from the 1950s, in which structural inequity in terms of the medical resources allocation across the urban-rural areas and the social classes was predominant. In all, the government's expenditure on the medicine and health did not correspond to its ideological claim. And furthermore, a huge gap existed between the urban and the rural areas. The other closely associated issue is the distribution of medical resources across different socio-political groups. In 1951 and 1955, the communist governments implemented the free medical services and the labor medical insurance. In addition, the Chinese governments had been implementing health care schemes for senior party officials since the Yan'an-based areas in late 1930s. So these schemes resulted in unrestrained waste of the medical and health resources and took up a huge percentage of the total public health expenditure due to the extravagance and abuse. However, the peasants who comprised the majority of the Chinese population had no medical provision except for the infectious disease inoculation, local disease treatment, and sporadic free medical services. The structural inequity of social medicine and health was not challenged until Mao's criticism of a Ministry of the Health in 1965. However, the structural inequity of medicine and health based on the inequality of treatment based on the social distinction maintained intact and continued until the late 1990s. So in the meantime, governments addressed the discrepancy between the ideological and the structural inequity through the administrative interference and the redefinition of the traditional medical resources and the disciplinary schemes. Administrative interference included the reduction of the pharmaceutical prices and sending the urban mobile medical teams to rural areas. By 1971, medical retail prices was only 1/5 of what they had been in 1949. So that was very significant for Chinese villages in 1970s. So affordable pharmaceutical contributed to equity of access to medicine and health when limited medical resources were unfairly distributed. But in the meantime, the Chinese government organized the mobile medical service teams for rural areas and to train rural health care workers in order to improve the medicine and health situation in Chinese villages. And the government also redefined the legitimacy of Chinese herbal medicine and to address the shortage of medical resources. The Chinese herbal medicine and acupuncture as low-cost methods to address the shortage of the medical resources were widely promoted nationwide, as reflected by the slogan, one silver needle and a bunch of herbs at 一根银子一把草. This confirmation further greatly enhanced the legitimacy of traditional Chinese medicine and completely ended its legitimacy controversy in which traditional Chinese medicine was scorned and as a moral medicine or neither donkey nor horse in the Republican era. The disciplinary scheme was a political cohesive measure. The official, the ideological discourse attributed the challenges and the suspicions of the villages to class enemies and attempts to kill the newly emerged sense of the Cultural Revolution in the cradle. The government extended criticism and the prohibition policies to class enemies and crack down on illegal, so-called illegal healers who may have continued practicing the medicine in the villages. So these disciplinary actions marginalize the competitors, the space of competitor of the barefoot doctors, and provide the barefoot doctor with much bigger space in which to practice medicine and develop a professional identity authority in the villages as a new types of healers. However, these efforts that address the discrepancy between the ideological equity and the structural inequity did not solve the critical issue of the limited funding for the cooperative medical stations and the barefoot doctors, which pose severe practical problems for the daily operation of the cooperative medical services. The initiation of the reform and opening up in 1978 redefined the legitimacy of the barefoot doctor program. And the key work of the health sector was now required to shift toward the medical and the pharmaceutical modernization. Through the new medical certification system, the states effectively changed the definition of the medical legitimacies by prioritizing the medical proficiency. The barefoot doctor also lost the core institutional context with the end of the People's Commune system in 1983. On January 24th, 1985, the Ministry of Health announced that the term barefoot doctors would no longer be used in China. Barefoot doctors who passed the medical examination and continued practicing medicine in villages were renamed village doctors. From the newly emerged scenes of the Cultural Revolution in 1968 to the renaming of village doctors in 1985, the history of barefoot doctors showed how the Chinese government defined and practiced the medicine and health according to the critical ideology, development strategy, institutional designs, the resources distribution methods, and operational procedure, and the disciplinary mechanism. In the meantime, the disease model was another determinant factor that shaped the medicine and health in rural China. By 1949, rural China was still afflicted by acute and chronic infectious disease, parasitic disease, and endemic disease. From the early 1950s, prevention and treatment of acute infectious disease, parasitic and endemic disease were mainly based on the two aspects. First, the Chinese government launched continuous public health and epidemic prevention and treatment campaigns. And the second, the Chinese government has been committed to improving the pharmaceutical and the vaccine technologies with assistance of something like the Soviet Union since the late 1940s. The epidemic prevention based on the mass campaigns and the technological improvements guaranteed the basic access to medicine and health, and facilitated the implementation of medicine and health scheme when China's medical system and resources distribution suffered serious structural inequity. The further progress of the pharmaceutical and the vaccine, together with the epidemiological features of the infectious disease, facilitated epidemic prevention and treatment. In China as a whole, the specific death rates from infectious disease kept dropping from 1957 to 1957. By 1980, the figure for rural areas had dropped to 20% per 100,000 and was maintained at this low level until 1984. Because of the consistent drop of the incidence and the mortality rates, infectious disease were no longer the main cause of the deaths for rural populations. Infectious disease ranked between 8th and 9th among the causes of the deaths from 1975 to 1983. The first 5 causes of death in both rural areas and urban areas were the heart disease, malignant tumor, and the cerebral vascular disease, and the respiratory system disease, and the digestive system disease. That means the disease model shifted from the infectious disease to chronic disease. But for Barefoot doctor, the higher profile was closely associated with the improvements in basic indicator on the infectious disease model from the 1950s to 1970s. However, the advent of the chronic disease model challenged the Barefoot doctors as a group because of the medical proficiency and subsequently impact on medicine and health in the following 2 decades. In all, by the late 1970s and early 1980s, the Barefoot doctor suffered the legitimacy and the practical crisis brought about by the renaming of village doctors and the change of the disease model. Contextualizing the impact of this dual crisis on Barefoot doctors in a long historical context can show the change of the roles of the Barefoot doctor and impact on the evolution of the community medicine. The Barefoot doctor played dual roles throughout the 1970s, in that they were both the healthcare workers and the physicians, particularly because the fulfilled healing roles. The Barefoot doctor had a similar medical expertise to commune clinic doctors. Furthermore, the popularization of brigade medical station, which had the authority to refer the patients to the top of the medical hierarchy, made the villages bypass the commune clinics altogether. The Barefoot doctors in practice thus further embarrassed the commune clinics, which suffer the poor medical proficiency, shortage of the necessary medical equipment, supplies, and the personnel to provide the medical services designated to them by the state system. The decline of the commune clinics made the rural medical network take on a dumbbell shape. The middle part, referred to the commune clinics, shrunk, while the top and the middle, the top and the bottom, referring to the county hospital and the production brigade medical station, become increasingly important. Therefore, the Barefoot doctors started to take over the medical practice in the local community that had previously been provided by commune clinics. In contrast, the commune clinics were like the medical management and monitoring agencies and were gradually marginalized in the rural community. The dumbbell-shaped structure of the three-tier medical system indicates the structural change of the community medicine that occurred from the late 1980s. And the dumbbell-shaped structure has continued to characterize the community medicine in rural areas since the early 1980s. However, the structure brought about by a few serious problems in the new era. The most immediate problem was the overuse of the Western pharmaceutical because of the villagers' doctors' prescription preference for profit and the rural residents' healthcare and seeking behavior and habits. Another critical issue is that each level of the three-tiered medical system was increasingly dysfunctional. And the basic aim of this hierarchical structure is to divide the patients among the three service sectors. However, as discussed above, there were no noticeable medical advantage to township clinics in comparison with the Barefoot doctors in medical stations. Furthermore, village doctors did not have any incentive to play the dual role of the health center. They were referring to the public health service provider and gatekeeper of the whole system. So when the medical market was highly commercialized in China in the 1980s and 1990s, all the social costs incurred by the overuse of pharmaceutical and hospital services was passed on to the patients. So given the problematic structure of the community in rural China in the last 2 decades of the 20th century, the Chinese government conducted a readjustment called integrated management of rural health from 2008 to 2010. According to the regulation, existing village clinics were abolished, while the county government established the new health service station or converted the existing village clinics into health service station. So each station was comprised of an outpatient room, a treatment room, pharmacy, and transfusion food room. And the health service station were located according to the 20-minute service circle. The village doctors were incorporated into these health service station. And the regulations specified that these health service center and station must provide 6-in-1 health services to villages, which encompass the prevention, treatment, promotion of health and well-being, and the rehabilitation, health education, and family planning advice. In all, the community health service mainly focus on the public health work. Meanwhile, they also provide the minor illness treatment service. So to curb the overuse of pharmaceuticals, the Chinese government has further designed the catalogs for medical units at each level. The doctors at the community health service center would only prescribe the pharmaceuticals listed by these catalogs. Through these measures, the government aimed to fulfill the integrated management of rural health in China in terms of the medical service, public health, pharmaceuticals, and personnel and finance. In the restructured community medicine's medical system, the role of the barefoot doctor, now called village doctors, were redefined, and the public health was re-emphasized. To some extent, the structure and the function of this system are similar to those of healthcare workers in the government and the non-governmental experiments program in the 1930s. So this means the ultimate goal of medicine and health in rural China continued across the new century to provide a basic medical and health service to the vast majority of Chinese populations and guarantee the accessibility, affordability, and equity of the social medicine. The Barefoot Doctor programs presented the Chinese approach to healthcare delivery and provision in China from 1949, which is evidenced by improvements in basic health indicators. And this method echoed the pursuit of the accessibility, affordability, and the equity of the public health and medical and health care in both developing and developed countries, in which the former suffered a serious shortage of the medical resources, while the latter encountered the issue of the health distribution on the dominance of the biomedicine. Thus, the Chinese government quickly utilized the health and the medicine as a special international politics and diplomacy tactics in geopolitical context of the Cold War since 1960, when China confronted both the USSR, Soviet Union, and the America. As early as 1963, China dispatched its first medical aid team to a foreign country, Algeria, right after its independence as part of the Asian, African, and Latin American people against colonialism, imperialism, and hegemonism. After initiation of the Barefoot Doctor program, the Chinese government usually included a model barefoot doctor in its friendship delegation to African countries. And together with the other health collaborations, Barefoot Doctor quickly influenced Asia, Africa, and America to some extent. In May In May 1972, the governments of the People's Republic of China joined the World Health Organization. Chinese medicine and the medical model based on the Barefoot Doctor program for the WHO's attention as the Chinese approach fits its grand goal of the meeting basic health needs in developing countries. In September 1978, WHO praised the China's Barefoot Doctor system as a model of the primary health care for developing countries in Almaty, former Soviet Union. Though the Barefoot Doctor program officially disintegrates in China in the early 1980s, it was still influential in Asia, Africa, and the Latin America countries. For example, in Peru, the Barefoot Doctors calls the health policymakers' attention as an inexpensive way of delivering the primary health care to rural areas when Chinese bilateral cooperation in health was blossoming through the former diplomatic relations and the Institute of the Culture of Peru and China. In the meantime, the Barefoot Doctor scheme facilitated the medical exchange between China and the West and played a specific role of a non-governmental diplomacy in the geopolitical context of the Cold War. The first USA medical delegation visited China in September 1971, just before the President Nixon's visit to China in February 1972. These American medical scientists and physicians introduced China's medical and health system to the American society, including the implementation of the Barefoot Doctors in rural China. So unlike those controversial acupuncture anesthesia, the Barefoot Doctors conquered the ongoing People's Free Medical Clinics of the Black Panthers Party due to its health activism, which was an ongoing of the contemporary occurrence and of its own organization evolution. And the Barefoot Doctor program also influenced some medical professional and organization. For example, in 1978, the Black Acupuncture Advisory Association of North America dispatched a Barefoot Doctor acupuncture cadres into the South Bronx in an effort to heal and resuscitate the improvised and minority neighborhoods. And to some extent, more significantly, Barefoot Doctor as an alternative mode of health provision also alerted a few American public health and social medicine professionals to reflect on the equity and the justice of health access in American society. So the conclusion, the history of Barefoot Doctor shows a unique development path of medicine and health schemes in the changing social context of China. The state has played a decisive role in shaping the medical and health development strategies and establishing and reforming the medical systems in Mao's era and in the post-Mao era and in the new century. During this process, the crucial and challenging issue for the state was to deliver its limited medical resources to the huge populations according to its proclaimed political ideologies of the equity and justice. And under the dominance of the politics of the state, the Barefoot Doctor as a representative of China's medicine and health scheme involved two sets of relationships. That is the traditional Chinese medicine and modern medicine, the administrative system with a medical system. Administrative system is and the medical system. In essence, this scheme aimed to provide a low-cost health care solution to Chinese rural population through the demedicalization of biomedicine, deprofessionalization, and the localization in the institutionalization of the medical system. However, the history of Barefoot Doctor indicates medicine and health in rural China could not avoid the dominance of the biomedicine, the trend of the professionalization, and the emergence of the delocalization, while medical institutionalization continued its momentum. This process occurred in the broad context of China's socio-political structural inequity from 1949, which had been further exacerbated by marketization and globalization since the early 1980s. And the disease model has been another factor in shaping the medicine and health schemes in China. And the pharmaceutical and vaccines have been playing the crucial roles in shaping the disease model and the impact on the Barefoot Doctor program. And in the last 2 decades of the 20th century, the state demonstrated both its ambivalent and the crucial role in the medicine and health in rural China. On the one hand, the state's eradication of duty in curbing the over-commercialization of the medical markets seriously undermined the equity and justice of medicine and health in China. On the other hand, the states and governments made steady progress in regulating and managing the village doctors and contributed to bring the medicine and the health into rural areas. The concept and the practice of barefoot doctors are transhistorical, and its aim and efforts continued throughout the 20th century into the new century. And in the new century, as in other parts of the world, population mobility, the radical change of the socio-political structure, and the unbalanced economic development brought about by urbanization and globalization are posing new challenges for the state to address the medicine and health in China. So the effect of Chinese new approach is still to be observed and assessed. So that's my presentation. Thank you all.
Absolutely fascinating, and I'm really looking forward to reading China and the Cholera Pandemic and digging really into this work as I consider adding a week or even 2 weeks on epidemics and epidemiology in modern China for my own third-year class. So, of course, work will be figured prominently in that. For the Q&A session, I'll just ask that for those who are present, just again, raise your hand, give a brief introduction of yourself. And since I'll be moderating the online one, for those who can hear me online and can see me, hello, please just type in your question and ask if you'd like me to read it for you or if you prefer to read it unmuted and proceed to the Q&A. Wonderful. Thank you so much. Questions?
I'm Luonan. I'm a PhD student in anthropology. My research topic is Tibetan medical professionals' work experience in public hospitals in Xiaoping.
Which area do you focus on?
Sorry.
No, I mean, which year, which era do you focus on?
I'm in my last year of PhD. So means probably a little bit or beginning of next year. Yeah. So it's a wonderful presentation. It helped me to understand a lot about Barefoot Doctor. That's sort of like my medical professional derives out from in a way too. So I really appreciate. And it's also proved that the Barefoot Doctor model is exactly the governance and disease combination function in your role in a way. So I guess my question is a bit detailed in a way. The first question is about, you mentioned since 1990s, is the inequity of medical resource of social distinction hadn't changed until 1990s.
Yeah.
And then by 2007 and 8, I guess the new health reform era, yeah, the role of village doctor re-emerged again. So what happened in between this period of time? It's 20 years.
I mean, from the late 1990, between late 1990s and 2007
and 8.
Actually, I'm a social historian of medicine, mainly focused on the history of Barefoot Doctor in Maoist China. But the Chinese government initiated the medical reform in late 1990s. It's around, I think, 1998, right?
Yeah.
Medical reform in 1998.
Uh-huh.
They just reformed the free medical services and labor medical insurance implemented since 1951 and 1952. So these two schemes cover those state-owned enterprise employees and other the employees working for the government agencies and such as I think factory or companies. But in 2000, starting from 2003, the government started implementing a new cooperative medical services scheme. It was called 新型农村合作医疗. So that reform started in 2003. And in 2009 and 2010, the government started a new round of the rural medical reforms, as I mentioned in my presentation. So just completely restructure the three-tier medical system. But my knowledge about the medical reform after late 1990s is limited because I did not focus on my research on the medical reform after late 1990s. But that's the basic knowledge I understand.
So my question was like, what's the village doctor's role plays during this period of time?
You mean from after the new rural medical reform?
Yeah.
Well, the government expected those village doctors to undertake the basic health care and medical work, and they are not expected to play the role of the physicians as before. In my presentation, I just mentioned from early 1970s to the late 1990s, the barefoot doctor or the village doctors played a dual role dual roles. One is the public health, the healthcare workers, and the other is physicians. But now the government expects you village doctors just need to commit to providing the healthcare workers. Just for example, conduct the family visits, register the patient information, and collect the epidemiological information. So they did not involve much work of the physicians.
So if the villagers get sick, they go to the village doctor, and they don't provide service there to cure, but they refer the sick person to county hospitals or township clinics.
Well, to be honest, I did my last field work on barefoot doctor in 2011. So I did not know the actual progress of this new rural medical reform of 2009 and 2010. I think just I mentioned that government expected village doctors to play the role of the public health providers. So that is only the very ideal institutional design. So I do not know how the progress was over the past decade. I think, to my knowledge, I think there should be many improvements because the barefoot doctor, both barefoot doctors and the newly established medical medical and health stations in rural areas cannot play the role of the gatekeepers, including the role of the referring, the work on the function of referring the rural patients to the county hospital or the township hospital. It is very difficult to implement such a policy. It's very difficult.
Thank you. Thank you very much.
Debbie, yeah.
Yeah, I would like to know that, yeah, whether the traditional herbal doctors, yeah, and the barefoot doctors, yeah, they coexisted, yeah, during the Maoist period.
Well, yes, and my study was mainly based on the village study. So my understanding of the relationship between the barefoot doctors and the traditional herbal medicine healer or the medical doctors is limited. But in my study, during my field work in the villages, I found there were still many traditional herbal medicine healer and the traditional medical doctors in Maoist China. And I mentioned just now, the governments redefined the legitimacy of these traditional healers, so they can coexist with the barefoot doctors. And for example, they can show the barefoot doctors how to identify the herbal medicine on the mountain, and they told them how to process this herbal medicine. So that happened only during the Maoist China.
Mentioned the barefoot doctor has changed into village doctor. The name has been changed. And I guess it was also under the context of trinity of risk evaluation and some more bring the medical system more scientific and more similar to the Western kind of medical institution. So I was wondering, like, during the Mao area, is that kind of barefoot doctor system like how it presents another way of health surveillance to the general residents, and also like how difference between the Maoist area, that kind of barefoot system, to a more like the westernized medical system China is using.
Sorry, could you please repeat the first question? You mean the surveillance of
the surveillance. I mean, like usually, well, according to some theory, like the government will, in the name of take care of their citizens, and then they post a kind of like the surveillance of the residents' health. Like, for example, like during the COVID, like people have to register if they are infected, or they do have a like a long personal record in their Medicare system. So like how the barefoot like represent that kind of public health surveillance in the Maoist area.
Yeah, I see. I think that's a very good question and a very big question. And I think, simply put, it is a very long and a gradual process. So if you are interested in this topic, you may read my my book. I already discussed how the governments collected epidemiological information among the residents during the corona pandemic in early 1960s. But it was a very challenging work for the government because it involved coordination between the medical system and the administrative system. So it is very difficult, but it is a long and gradual process. And now you can see over the past 3 years, the governments perfectly combined the institutional control and digital surveillance control, so they know everything. So that's the history development process.
How many of the barefoot doctors turn into professionalized medical workers after the system has transformed or reformed in the mid-1980s?
No, when the government renamed the barefoot doctor to village doctor in 1985, there was no such a medical qualification system for village doctors. So as long as this barefoot doctor passed the medical examination and they are willing to continue their medical practice in villages, they were eligible to practice the medicine in 19 1980s. But by the middle of 1990s, some provinces across China started implementing something like the medical qualification system. So they had to pass the examination. Otherwise, they will not be allowed to practice medicine. But it depends on the location of these village doctors. For example, in Zhejiang province and other southeast coast areas, the government implemented this policy very strictly since 1990s. I'm sorry, I don't know the exact number of them.
Thank you.
Question on the effectiveness, of the Barefoot doctors. So I wonder, if all the commutes, they have at least one Barefoot doctors, and
Sorry, could you repeat the first part of
so I am thinking about whether there's comparison between their commute with the Barefoot doctors and without. So what's the impact on the health in the community?
Oh, you mean the impact of the barefoot doctors on the community?
Yeah.
Without.
All the commute has at least one barefoot doctor.
No, I don't know. I think in Maoist China. In Maoist China, the government required each production brigade to have two or three barefoot doctors. So in each commune, there were many barefoot doctors. The number of the barefoot doctor is quite big in Maoist China, but the quality was quite different.
Welcome. I just wonder the level of competence of these doctors in our experience, and did they continue in the 80s and 90s? Were they still called barefoot doctors? By then, China was getting richer. The kind of training they had. If you compare these doctors, so-called doctors of the 1990s, compared to, let's say, our nurses and whatever, I mean, what kind of level do you face?
Saying you mean the medical professions of the barefoot doctors? Yes.
I mean, what type of
I
mean, medicine is so advanced.
Yes, definitely.
What type of training? Because you said that by a certain period, was in the 90s, that they don't. In some places, they did not want these. Do they call them fancy doctors at that time?
Oh yeah.
To prescribe medicine for them.
Yes, good question. Government renamed the barefoot doctors to village doctors on the official documents in
They call them. They still call them.
In the daily life, the villages still call these barefoot doctors barefoot doctors. They did not call them village doctors. Nowadays, we still call them. I'm from a village. We still call these barefoot doctor, former barefoot doctor, still call them barefoot doctors.
What type of training do?
Oh, in the barefoot doctor. Okay, today. Well, still, my research is based on a case study in Zhejiang province. So my understanding of knowledge is limited. So I hope my explanation will not mislead you. Okay, in Zhejiang province, during Maoist China, barefoot doctors receive think around 10 months of medical training on average. 10 months from late 1960s to early 1980s. On average, each barefoot doctor received 10 months medical training in Maoist China. But after the renaming of the barefoot doctor to village doctor in 1985, the government has been very strict with the the medical professions and the quality of these barefoot doctors. So for those barefoot doctors who continue practicing medicine in villages, they were required by the county health bureau to attend regular training every year. Otherwise,
the medical training.
yes, medical. Anyway, the training organized by county health bureau, possibly at a county hospital or county health worker school. So otherwise, the barefoot the village doctors, village clinics were not. They had the village doctors clinic had the business certificates. If business certificates, 营业执照, yeah, such as the certificates. Otherwise, they were not allowed to practicing the medicine in the second year. And starting from the 2003, I think the government implemented much more strict policies. So the quality of the village doctor, quality of the medical professions of the village doctor has been improving. And in Maoist China, because of the medical professions of the barefoot doctor, many of them committed medical malpractice. And the government proclaimed they were the newly emerged things of the Cultural Revolution, so they were not criticized and punished by the medical malpractice incidents and misconduct.
It's more like a comments responding to that question, because I did my work also back in Xiaoping County, which is like county hospital related to township clinics and village clinics. And most of the village doctor right now is like having sort of medical certificates, either graduated from diploma school or from like a background like a not quite university but university school, and they couldn't pass those exams to go to of being a doctor in contact with home, but they could pass on certain exams into the village or township clinics to be a doctor there, and then the local house bureau or the regional house bureau, provincial level, or the county level, or the municipal level organize trainings each year to sort of like consolidate their medical skills.
I wonder, like, there were like incidents of chicken blood therapies, and also maybe do they provide, like, for example, like reproductive health roles, like do they act as midwifery in villages, or they are just practicing like normal medicines?
Sorry.
Midwifery, like do they接生?
When in Maoist era?
In Maoist era.
No. Think the women barefoot doctor. Yeah, women barefoot doctor. Some of the women barefoot doctor do the birth delivery in some villages. Some of them.
So just follow up question. So you mean like during the Maoist era, so only like women barefoot doctor would like to do the midwife things, or only those women barefoot doctor are supposed to do something?
Well, it is understandable because of the cultural taboo.
Oh,
But the men barefoot doctors were not acceptable by
Oh, okay. But so compared to Mao's era, this is nowadays like there's still male doctors doing some things in the like.
No. Nowadays, all the expectant, the mother, are requested to stay in the hospital before the birth of the baby.
Fair enough.
Yeah.
Fair
And then the C's and also the C's as intersection. What's C, yes, it is very popular and very serious in China, in both urban and rural China.
You could comment on the intersection between the doctors and the midwife system in China and how they interact with it all, and also we could also call alternative thinking. If they will still have a propensity to up to you, there's something here. The famous one of that. There's also some other alternative medicines. I know in India there is a lot of pseudo-doctors who much other health and made, but one of the biggest chains there is the biggest alternative medicine chain you ever know. So given they're only slightly medical trained, they're on their own how much the tendency to perhaps use alternative medicines or whatever that can't use and the interaction with the
Well, so the government during the Mao's era promoted the Chinese herbal medicine and acupuncture, as I mentioned. Yeah.
I'm just wondering if that then brought about, if that's okay, then why not everything else is talking about?
Well, as I discussed in my book, it is quite difficult to practice some the skills of acupuncture and even so-called low-cost Chinese herbal medicine. It is much more difficult to practice this skill and prescribe the herbal medicine than prescribing the Western medicine. The Western medicine was much easier for the barefoot doctor in Mao's China to understand and practice. Well, in Mao's China, there were still many traditional midwives, but women barefoot doctors were commissioned to undertake this work because they are accepted by the families.
On that road, do you do case studies of the so-called chicken blood therapy, 打鸡血,
Okay.
in your case studies on barefoot doctor, because it's like a well-known phenomenon regarding mostly barefoot doctor practice.
Yeah. Yeah, I know. Yes, government in starting from the Great Leap of War, 打鸡血, blood, chicken blood. Yes.
Yeah.
No. Yes. Yeah, the government during the Cultural Revolution promoted many the folk methods and the folk recipes, but it was this practice and the recipes were not so popular as the government's official discourse proclaimed. So I think we do research on Mao's China, and for us, I think the most challenging work is to interpret the official discourse and compare the official discourse and the practical, I say the daily practice. So that's the difficult. Anita may have much more experience.
Certainly.
I just think that during the Maoist period, everything was rosy.
Oh yeah.
Okay,
Yeah.
a lot of everything. All right.
Yes.
So
Yeah.
everything was good.
Yes, chicken blood recipe, the therapy sounds very fancy and very popular, but it was not so popular among the villagers.
The Chinese elite themselves, the Politburo, or as far as aware, the data they use, the doctors that they use, what you're calling Western doctors, non-school doctors, are they doctors or are they?
Well, this barefoot doctor program was a medical and health programs implemented in rural China. And for those senior party officials and the state-owned employees and other the party or the governments, the officials, they had their own medical schemes, such as free medical services scheme and labor medical insurance. Pardon?
Did they special scheme give the doctor stuff?
Oh no, definitely not. Yeah, no. Because the Barefoot Doctor applied a low-cost solution.
Yeah, completely different topic. I was wondering if you had some more information on the internationalization of the Barefoot Doctors, like the exchange with the Fang, for example.
Well, yes, I mentioned a little bit about the. Well, usually with the current scholars claim WHO pre-claim that the Barefoot Doctor was a model primary health care scheme for the developing countries, and just I mentioned like the people's people's free medical clinics of the Black Panther the party. And yes, the two the Barefoot Doctor programs echo the theme of this medical scheme in America. But I haven't done much research on the comparison between the Barefoot Doctor program and those in other developed countries.
Especially considering it was such a localized practice.
Yeah.
I'll kind of jump off of that one. So you mentioned, I loved the slide that you had on Latin America. I'd be remiss if I didn't ask if you could elaborate or point me in the right direction on the intersection of the Barefoot Doctors and maybe the Southern Highlands of Peru, where there was a certain Maoist movement happening in the 70s that was actually trying to emulate Rinpa Dagening in theory and in practice. Because there's really not a lot out there. That's really fecking grounds for some exciting research there. Because you hear a lot about Peruvian intellectuals going to China and learning from what they experience in the classroom, staying in the Yafela, Pichon and stuff like that. But Barefoot Doctors going to Peru. Now that's exciting.
So have you ever read some materials about the medical and health scheme in Peru, in most
in Peru at that time, yeah, in the rural sector, during the Fujimori years, it wasn't great towards indigenous communities, as you can imagine. But I'd be curious to know about Barefoot Doctors, especially considering Peru has a very large Huaqiao population, or
in most China.
In Peru during that time. Yeah, absolutely. Yeah, one of the big kind of star features when I was doing my research in Xiaoping, going to the Museum of Migration, finding out that Peru had, by their estimates, 1/10 of its population had been descended from Chinese migrants, which is fascinating. I'd always thought Brazil or but yeah. So I was just curious if there's a lead on that. If there isn't, then that is an exciting avenue that hopefully someone will go down. A road that someone will go down. But, be fascinating. So, I'm pretty sure Sendero Luminoso, the Shining Path Maoist movement, had their own effort to try and create a Barefoot Doctors of their own, with mixed results. I'm sure.
So no one has worked on this topic.
No one's worked on this topic, at least not in Anglophone scholarship. I'm still digging around Spanish scholarship. I'm sure Gonzalo Portocarrero has done something, but yeah, sorry.
I do read a couple papers on the Ben's revolutionary medicine, which is like they output their own medical professionals to other countries to help them their the other countries people to help with subsidies from previous governments to these medical professionals. It's a very interesting topic that it's like relevant research. So there's a lot of documents. So I think I'm pretty sure the Malaysian Communist Party send their comments to China. They and a lot of them were women, and we will send back to the Malaysian jungle to treat them. So it's fascinating how they managed to bring all these medical facilities into the jungle and treat their comrades and also local villages. So local villages were really happy to get treated with these advanced professional Western medicines which they were not able to access. So kind of thankful for the Communist Party being able to do that. So I just wonder whether I'm sure that they get training in China, but on at what level or every doctor system will kind of evolve, or is it purely like a communist network effort, or have any information?
I think, to be honest, I have never heard of a Malaysian Communist Party member receiving the medical treatment in China. Yes, training in China. Because I have participated in the Cold War project in 1945 to 1990. We focused on the Malaysian and the Indonesian Communist Party and the relationship with Communist China during that period. We have collected some materials, but we also invited some former Malaysian Communist Party to have a dialogue. And I have not heard of this the medical treatment. Anyway, they did not. I think that's a very good question. That's a very good question. We only know Malaysian Communist Party had a broadcasting station located in central Hunan province. But we do not know whether they have received medical training in China. Maybe that's the Communist Party provides the guerrilla medical training to this Malaysian Communist Party who fights the foes in the jungle.
So many potential avenues for global, or kind of the global dissemination of this. Yeah, it's really quite
I
fascinating.
think that's a very good perspective. Topic.
Wonderful. Well, we have had I love the dialogic nature of the Q&A. I have to say, like, really, really rich. And as Professor Fang noted, it's a busy time for everyone. So we're really grateful to have everyone here and have such enthusiastic participation and questions. So I'll adjourn our meeting, but before we adjourn the China Seminar Series for today, a round of applause for our speaker, Professor Fang. So grateful to have him here. And thank you everyone who joined us online. We had a great turnout overall, honestly. I'm always blown away by how many you guys put the format. So to have so many people in person and online, so really grateful for that thing. So thank you so much. Thank you guys.
当时说是如果跳过是他们知道那个这样不是的话，我不了了，不知道为什么上
By all means, yes, please.
当时外国跟我说，我会之前的
If they don't, I will get a PDF.
到底有没有瞎嘛？对不对？
Everything I'll
第
get.
二种话就是说
Yes. I'm making the fine. Matthew Galway. I've got an AU page and everything.
然后很多人就中医疗嘛，就因为老喜欢中医嘛，就当时就搞成这个样子了。
Two T's.
不是，然后甚至是，然后后面就是说，
Galway, GAL.
不好的一点
WAO.
30
Yeah. And I got an AU page. My email's up there. Shoot me an email. Hook you up. You got it.
维是一汤指的是葡萄糖，
Should be one directly to your right.
叫3次汤是吧？
Yeah, you go out and right.
这东
And
西
if you need a card,
就是说，不管是谁，反正这个东西我死不了，我这个看看这个东西。 China and the Florida pandemic. 怎么来着？我是不是学习重病啊？哦，好像可能是的。霍乱。拍照没扫进去。啊，不过不得不说，当时这个也算是一种良政吧，某种程度上而言，对吧？它确实是限制了疾病的传播。 主要是它的那个效率是很高的。
你想想，这次 COVID 如果没有这些 barefoot doctor，乡下会很糟糕。
啊，确实，我当时来个人算什么？先开一关默契加薪，然后默契加薪，抗人会回来，不进去往下靠人都是对，但是说当时出了一个很大的消落人，可能里面就是对老人并不是加小整，是一个新的来，所以说先下一个，然后再说。
And some people, you know,
对啊，这个
as long as we don't have any. Yeah.
Yeah, because I've got one other receiver right now. And two, but there's nothing that's the main focus because it's such a. The main focus is something but there's a lot of things. It's not just about. Very fascinating narrative. There's a light through the leaves. It's all about doing correspondence and nobody's ever compared and no one it should be fun. It should be a fun talk. It's mostly going to be experimental. Yeah, the time I got a very grateful. So I'm hoping to do that. Just got hoping to go to support them. We'll reconcile. I just want to know whatever they want. It's supposed to do. I'll do it again. It's been longer now. How long?